let me tell you one thing. We have got singers in our country, as you all have. So none of them, most of them cannot sing in live concert. They presented this, recorded ones. It's all over the world. It's like that. So in this exam as well, it's the same. It's very difficult to face stations that you are not prepared with. You are not prepared to address that. So what is important? You need to have a structure. You need to, first of all, if you need to understand how to do it first, regardless of the recalls. If there is recall, so it will give you just information that these are the topics that they're interested in, but it may not come in the exam. And maybe the same title comes, but the questions inside the booth is different. If you go inside the station, questions are different. I'm the examiner. This question comes in my brain. I'm asking you. You need to answer it. In my RCPI exam, there was one station about the third degree perennial tear. The examiner asked me a lot of questions, which I was not prepared with. Only my general knowledge and my experience could answer those questions. So these are the things that you need to practice from the very beginning in a way that you should be able to answer any sort of question about that specific topic. Okay, do not go blindly. Do not go with anybody else's PDFs or structures, because that is, for example, my PDF is my PDF. It is not Sona's PDF. Sona will have other points, in her own notes. So we are different. This is the exactly most important difficult point in these exams, So as an example, now I'm gonna work on one labor word prioritization task that most of us, we fail this task. We are not able to finish it. There can be 7 patients, there can be 9 patients, there can be 12 patients. How can you, in 10 minutes, address this 10, 12 patients? There are important points that you need to understand before addressing this specific station, okay? So who is ready to do this with me? Is there anyone? First, we need to do it first, and then I will say what is the first, second, third, fifth point that you need to understand and say it. And how can you pass this station? This is a must-come exam in station in MRCUG and in MRCPI as well. Okay? Because without labor ward, you won't be, without managing a labor ward, you will not be considered ST3 to ST5 level in any of these colleges. Yeah? Come on, one of you, Nazia, Anas.
Yes, I'm ready.
Okay, Nazia. Okay, Nazia. So I'm gonna give you 2 minutes. So imagine that you're in front of a booth. Okay?
Yes.
Just your eyes, your brain, your mind, everything should be with this station only. Okay? And now I'm starting my 2 minutes. Yeah? I'm starting my 2 minutes. Take your time. I'm gonna change this. Yeah, one important point is that there are so many papers. How to know that this paper is important, this is not that important. If you answer this, you will pass. If you answer that, it is not important. You will not get anything from it. Okay? So and then I will tell you what are your problems later on. So 2 minutes starts from now. 1, 2, 3, starts. Start, please.
Yes.
Yes. Next page. Can you see the rest of the patients?
Just previous page. No, just 4 patients.
Okay. Now this is the 5th, the 6th, the 7th, 8th.
8. Okay, okay.
Yes.
Shall I start? My 2 minutes finished.
Okay. Okay. So now it's finished. Now your 10 minutes starts. Okay. You are inside the booth. 1, 2, 3 starts. Start, please.
Hi, I'm Nazia Zihan. I have taken the charge of the labor ward at 9 a.m. and I will consider the available staffing. My ST2, ST5 anesthetists and 5 midwife is with me, and I will assess their clinical activity and will determine the competency of the members of my team. And I will take a panoramic view to the board, and then I will quickly go room by room, ask for more details of the patient to aid in prioritization and ensure no patient is left unattended. Coming to the room number 1, she is patchy 1, 40 plus 2 weeks pregnant, and cesarean section done at 3 a.m. due to failure of second failure in progress in second stage of labor, and expected blood loss is 2.5 liter. And just check a full blood count at 9 a.m. I want to know whether bleeding is continuing or not. How is her vitals sign there?
Okay, so this is atopic uterus in theater, contracted with ergometry non-syntocinon, now trickling bleeding, pulse rate is 130, blood pressure is 90/60, urine output is 100 ml since the theater.
Yes, this is urgent case, and as her hemoglobin is 7.5, I will inform my consultant and activate major MOH protocol and inform ST5 anesthetist and hematologist and ensure urgent blood transfusion if there is no restriction of blood transfusion. And then urgently I will initiate IV fluid and blood regarding the ABC management of the patient, oxygen either needed or not, and manage these as urgent cases. Involve my midwife here also. And second, please, room number 2.
Okay, 2.
Room number 2. She is a parative second, 38 weeks pregnant, previous 2 cesarean section planned for elective cesarean section. Now has 3 contraction in 10 minutes, 7 a.m. Okay, I want to know whether is any risk factor is there, how is her vital stable or not, PV examination done or not. What is the PV
So
finding?
this patient is stable, vital signs are stable, fully effaced 4 centimeters, membrane intact, CTG normal.
4 centimeter. Okay, so this is a semi-urgent case. I will involve my midwife and ask my ST2 for taking information consent and inform my consultant also. And as it's a semi-urgent case within category 2 cesarean section will be arranged for this patient. Room number 3. Please, room number 3.
Yes, 3.
3, she is a primary patient, 41 weeks pregnant, baby born 8 a.m., placenta still in situ. I want to know whether how much blood loss and whether bleeding is continuing or not. Is there any risk factor is there?
So this patient, blood loss is 1.5 liters and is continuing. Pulse is 120, blood pressure is 172. How do you manage this case?
Yes, it's a urgent case. Urgently, I will inform my consultant and ST5 anesthetist also, and ABC management will be initiated for that, and PPH protocol I will follow. Major obstructive hemorrhage for major obstructive hemorrhage, and in this case I will urgently shift her, ask my midwife to shift her to operation theater for to arrange for manual removal of placenta in the presence of my consultant. It's an urgent case.
Okay. Shift to theater, right? For what?
And, for manual removal of placenta. as placenta still in situ.
Okay.
After
What else to
managing,
do? What else to do?
just follow the as is massive hemorrhage. I will follow the PPH protocol. Urgent uterotonics will be given. Oxytocin, misoprostol, and second, third line uterotonic will be given. Tranexamic acid I will consider, and simultaneously IV fluid and blood arranging for that. And then if need balloon catheter.
Okay.
And then if need surgery, I will do for the. In case of room number 4, as is parity 5, 39 weeks pregnant, induction of labor for expected fetal weight more than 95th centile. So she is at 6 a.m. 6 centimeter dilated and cephalic station -2. I want to know her last ultrasound of expected fetal weight and whether any history of what is her previous of history, there any history of PPH or shoulder dystocia, any history of like that.
Yeah. So
Now,
she has got history of
stable.
PPH. She has got now stable vitals. CTG is normal, and fetal weight is 4 kg.
Okay. Now, as she just a previous slide. As she's multiparous,
Para 5.
it's para 5, yes. Para 5, it's full, yes, yes, 10.
Oh, okay. Okay. So what is the priority?
Not this case, just from number 4, I think. Yes. And as she's full alert, it's an urgent case for me. I will involve my midwife for continuous monitoring of this patient, and there is chances PPH and shoulder dystocia can happen. So during the time of delivery, I will inform her to call my consultant and me, and their active management of her stage of labor will be there, and prophylactic symptometrin will be given if there is no drug allergy. No allergy to any this drug. And next, room number 5.
Yeah.
Room number 5, she is 28 weeks pregnant, preterm labor steroid given 3 days ago. Cervix is 4 centimeter dilated at 8 a.m. I want to know whether a membrane rupture or not, whether any risk factor is there, how is her vitals, abdominal and vaginal findings.
So stable vitals, normal CTG,
yes.
cot is available,
Yes.
cephalic, shrunk 3 days ago, and she is contracting 3 in 10.
Yes, it's a semi-urgent case. I will involve my midwife here as she's taking steroid. I will advise her to give magnesium sulfate for neuroprotection and interpartum antibiotic prophylaxis if she is not allergic to penicillin. And this is a semi-urgent case. For me, room number 6.
Okay.
She is 42 weeks pregnant, induction of labor for post-maturity on epidural. A normal CTG and cervix is fully dilated 6 a.m. Pushing for 1 hour as she is already fully dilated for 6 cm. This is an urgent case. This is an urgent case. I want to know whether there is any risk factor. How is her vitals? CTG.
Yes. So stable vitals, contracting 3 in 10, but they are short lasting. And she's fully dilated and LOA 1 centimeter below the spine.
I will involve my midwife and inform my consultant as she is station +1. There is a delay in the second stage of her labor, so may need to shift her OT for instrumental vaginal delivery. So consultant will be informed that this is urgent case.
Okay.
And room number 7, there she is 42 weeks pregnant, having pathological CTG, cervix is full dilated, pushing. I want to know whether there is any risk factors there. Her PV findings in details.
Spontaneous labor, contracting for intent, aid not by palpable